So let's talk about how to optimally use the laryngoscope while intubating a critically ill patient or for emergency intubation. So there are several types of laryngoscopes which are available. The first one is the standard Macintosh blade direct laryngoscope, and the others are types of video laryngoscope. Some commonly used ones are glidoscope, CMAC, McGrath, AirTrack, and King Vision. So let's start with a question. Which of the following is a recognized limitation of videolaryngoscopy during intubation in critically ill patients? A. Inability to visualize the vocal cords. B. Difficulty advancing the endotracheal tube despite a good laryngeal view. C. Increased incidence of aspiration compared with direct laryngoscopy. D. Requirement for spontaneous breathing during intubation. I would like you to add the correct answer. What you think is the correct answer in the comments. So video laryngoscope, as you can see in this figure, provides a better field of vision than direct laryngoscopy. So as you can see, video laryngoscope can increase the view from this to this, from a POGO score which is low to a POGO score that is 100%. POGO score is percentage of glottic opening score. Classification. Various laryngoscopes, video laryngoscopes have been used in trials involving intubation in emergency, acute care or critical ill. They can be mainly divided into three types. The first one are standard geometry or Macintosh shaped video laryngoscope. Here the shape of the blade is very similar to a direct laryngoscope. They provide a view in the screen of the camera. However, you can also directly visualize the vocal cords when you do a laryngoscopy through these laryngoscope. A common example is McGrath, which is shown in this picture. So these are easier to operate and the learning curve is not too steep. Anyone who is experienced in direct laryngoscopy can try these video laryngoscope. However, the disadvantage is the field of view might not be as good as the other video laryngoscopes, which we will see next. So next is the hyperangulated video laryngoscope, which is not channeled. One example is the glidoscope or CMAC D-blade laryngoscope. So what is different is that their blade is very angulated. They provide a good vision of larynx or vocal cords, however only through the camera. You can't see the vocal cords directly with the naked eye. The path is not straight, so you will need a special curvature in your endotracheal tube if you want to intubate using these scopes. So for this we need to put a stillet inside these laryngoscopes. Plus another problem is the learning curve for using these scopes is rather steep and you need practice if you want to intubate with these scopes. The third is channeled or conduit types laryngoscopes. So these scopes try to solve the problems with both the first and the second types. The blades of these laryngoscopes are hyperangulated, so you get a very good view with minimal motion of the neck, as was true for hyperangulated non-channel tubes. However, they also have a channel and the endotracheal tube is already has to be fitted before performing the laryngoscopy inside this channel, which takes a particular shape. And once you get a view, you just have to push the tube into the vocal cords or trachea. So you don't need a stillet. Plus, the learning curve is better. You can learn them relatively easier than non-channeled scopes. Example is AirTrack or King Vision video laryngoscopes. So now let's talk about what is the evidence for video laryngoscopy in critically ill patients or for emergency intubations. Whether it is better than direct laryngoscopy, should it be used only during suspected difficult intubations or should it be used routinely? So the first large randomized trial published which tried to answer this question was the Macmillan trial, which was published in 2017. The authors found that videolaryngoscopy did not improve first pass success, and use of videolaryngoscopy was associated with higher severe life-threatening complications. What the authors reported that though the view of the glottic opening was excellent with videolaryngoscopy, there was difficulty advancing tube into the glottis in spite of the excellent view. The major reason for this was majority of the operators were inexperienced. They were trainees and residents. They were not well versed with the use of the video laryngoscope. The video laryngoscope used in this trial was the McGrath video laryngoscope, hence the name Macman. In fact, several observational studies suggest that there is a steep learning curve for successful use of video laryngoscopy, especially in emergency non-operation theater settings, which are not very controlled settings. Up to 75 to 76 VL attempts are needed for 90% optimal performance probability. This was also shown in the study that the first pass success rate in the first year of training was 74%, but in subsequent years it increased to 84 and 90%. In fact, around 6-7 years back, when this trial was published, there was another observational study, INTUBE trial, which recorded in how many of the emergency or critical care intubations video laryngoscope was used. So they reported that only in 17% of total intubations VL was used as compared to DL use in the remaining intubations. That was a staggering 83%. Of note, VL was mostly used when difficult airway predictors were present and difficult airway was suspected. However, over the last few years, the use of VL has increased worldwide, and the evidence was again searched, and this trial was performed in 2023, that is, much recently, by the name of the device trial, which was published in NEJM. This was a large multi-center randomized trial conducted across 17 ICUs and emergency departments worldwide, and it compared video laryngoscopy versus direct laryngoscopy in critically ill adults. But the authors found that successful first attempt intubation was seen in 85% of the cases with video laryngoscope as compared to 70% with direct laryngoscope, and this was statistically significant. So, in this trial, the video laryngoscope outperformed direct laryngoscope. The meta-analysis published in 2017, that is prior to device trial, showed that after pooling the data, there was no significant overall difference between VL and DL scope with respect to first attempt success. However, esophageal intubation was reduced with VL as compared to DL. However, the pooled data after inclusion of the device trial showed that VL use is associated with higher first pass intubation success with the odds of 1.5 and also lower esophageal intubation risk, that with the odds of 0.44. That is, the incidence of esophageal intubation reduced by almost half if VL was used. Based on this, the guidelines recommend strongly that VL should be used as a first line device for tracheal intubation in emergency settings, that is, non operation theatre settings. Now, we know that the VL is better and it should be used as a routine intubating device. However, as we have learned that there are three types of VL scopes, so which one is the best? A network meta-analysis which was recently published showed that the lowest odds of failed first tracheal intubation was present with channeled blades. For example, the King Vision scope, and these were better than the anatomically shaped laryngoscopes or hyperangulated laryngoscopes which were non-channeled. Also, there is a ongoing trial by the name of InviBlade ICU, which is comparing non-channeled hyperangulated blades with a standard geometry blade, and the results will be out soon. So this was it for video laryngoscopy used in the emergency settings, including critically ill. If you have any questions, you can post them in the comment section. Thank you.